Hi, I'm Casey White, and this is my case study for MLS 461. We have a patient that is a 60-year-old male that presents to his primary care physician with a blister on his foot that won't heal. He received the blister while helping his neighbor install a hot water tank where the previous one had been leaking in his basement. The patient presents with a blood pressure of 132/98, a body temperature of 99.1, and an oxygen saturation of 96%. His symptoms is heat and soreness around the blister site. It is small and does not appear necrotic. It's warm to the touch and mildly swollen. There's some indicators here of infection, the 99.1 body temperature and the oxygen saturation of 96%, which is slightly decreased.
Nope.
The patient has a clinical history, which includes type 2 diabetes mellitus, peripheral artery disease, and hypothyroidism. The physician suspects a mild infection and orders a piperacillin and tazobactam injection to help jumpstart the healing process. The physician requests that the patient come back in 3 days if there's not been any change in the blister. Due to the patient's clinical history, it's really important that this is healed as quickly as possible to prevent sepsis. 3 days later, the patient presents again with a new blood pressure of 112/74, so markedly decreased from last time, a temperature of 101.2, which is elevated from last time, and an oxygen saturation of 94%, which is also decreased. The wound now appears to be very warm to the touch and is red with white splotches and has visible pus, so that's another sign of infection. The new things to consider here is that the patient's status is declining and that there's some possible bacterial resistance due to the increase of the body temperature and the worsening of the wound site and the decrease in oxygen saturation. The patient could become septic at this point. So the new treatment plan is to order a culture and sensitivity of the wound, a CBC and a basic metabolic panel to get a baseline of what's going on in the patient's body, and to use a new broad spectrum antibiotic until the culture report is back. The significant lab results that were found in the CBC, basic, and culture are a white cell count of 18.2, neutrophils at 82%, toxic granulation, and vacuoles are noted on the smear. Toxic granulation, vacuoles, the 82% neutrophils, and the high white count are all indicators of infection. The significant basic metabolic panel findings is a glucose of 346, which makes sense since the patient is a type 2 diabetic, especially if the patient was not fasting at the time. But however, the increased glucose can also be due to infection as well. And CO2, which is slightly increased at 34, which is one of the first indicators of sepsis due to the fact that your CO2 indicates a disruption of the pH balance in the body. The microbiology culture report grew a gram-negative bacilli that was a yellow pigmented colony on the TSA and was a non-lactose fermenter on the conky. It was oxidase positive. And the colonies also gave off a very distinct fruity odor that smelled very similar to juicy fruit gum. And you can see here on the plate are some of the colonies. They're kind of a yellow pigmented. They're not beta hemolytic. And after the identification and susceptibility was completed, the laboratory reported that there was growth of Myroides odoratimimus, and this organism is resistant to several drugs. And one of these drugs that it shows resistance to over here is piperacillin and tazobactam. One of the better choices would have been either ciprofloxacin or levofloxacin, which has the S's beside it. In conclusion, Myroides odoratimimus is a very opportunistic pathogen, and it's mainly found in contaminated water. It typically does not cause sepsis. The spread of infection was made easier due to the fact that the patient was a type 2 diabetic with peripheral artery disease. Type 2 diabetes, the increased glucose will help increase bacterial growth rates, and peripheral artery disease will slow the healing process of that wound. The patient was most likely exposed to this whenever they were changing the neighbor's water tank and the previous one was leaking. There was probably contaminated water in the basement. While it's not normally responsible for sepsis, this patient was immunocompromised by the peripheral artery disease and the type 2 diabetes, and that it will hinder the ability to heal. The peripheral artery disease will, and then also again the increased glucose will help the bacteria thrive. The course of treatment now that the bacteria has been identified is with the patient showing signs of sepsis. The doctor would like to have the patient admitted and receive IV Cipro, and then also to be monitored for septic shock. The patient was discharged after 48 hours and his body temperature and everything returning back to normal, and was sent home with a 10-day course of Cipro orally. And then the recheck of the wound was 1 month later after using the ciprofloxacin. It was healed and is no longer causing pain to the patient. Some unique features about Myroides odoratimimus. It is aerobic, yellow pigmented. That distinct juicy fruit odor is very, very characteristic of this bacteria. It is a gram-negative bacilli, and it exhibits growth not only at 37 but also at room temperature. It does not ferment lactose and is oxidase positive. It's considered a low-grade pathogen, but it is considered a low-grade opportunistic pathogen and is typically found in wet environments, insect guts, and seawater. And during the research for this, I had found that there's actually been no reported infections from insect bites of the Myroides species. So it's mainly just found in contaminated water. The final thoughts from this is that Myroides odoratimimus should not be ruled out in the case of an immunocompromised patient, because with having an immunocompromised patient, it would make it easier for the bacteria to thrive. And it should always be considered as a possible source of infection in a nosocomial infection due to the possibility of the organism living in water supplies. This is also a very good explanation or example of why the collection and processing of these cultures are, the turnaround times are very important. Cultures only grow so quickly, but with the quick turnaround time that you can receive on, say, like a Vitec or a microscan or something like that, will really help affect the patient outcome and the course of treatment. Otherwise, this patient could have easily become septic and had a worse outcome. But otherwise, this patient has healed and has returned back to their normal daily life, and the Myroides odoratimimus is kept at bay. Thank you very much for watching my case study. Here are all my works cited. Thank you.